Awesome. Welcome, everybody. Good evening. This is Pete Stibbs. I'm the Vice President of Global Medical Affairs for Argon Medical, and welcome to our ACES virtual initiative event this evening. Tonight, we're excited to have Dr. Neal Khurana, a vascular interventional specialist and interventional radiologist, and Dr. Steve Henao, a vascular surgeon. And tonight's going to be a little different format than what we normally do. Instead of just having straight case presentation, we're just going to kind of have a discussion and talk to Dr. Henao and Dr. Khurana and talk a little bit about how they work together in synergy in practice. Gentlemen, it's nice to have you on board. Like I said, this is going to be laid back. In fact, it was a little tenuous. Dr. Khurana was just finishing up a procedure, and talk about last minute. He was able to hop on right before we started. So it's great to have you both here and both available. During the process of this discussion, if you have any questions, please feel free to post them in the question box. We'll make sure that we get to them before the end of the evening discussion. But I want to welcome you both and thank you for joining us. It's awesome to have you.
Thanks a lot, Pete, and thanks, Steve. It's nice to see you outside the office, kind of. And I just want to thank everyone for joining us. You know, when Pete said that I just came from a case, it was literally 1 minute ago. I'm in my office, and our OBL is 100 steps away, and I just finished a 2-level kyphoplasty. We were running a little behind today. You know, we had 6 angiograms, 4 vein closures, kypho, gonadal vein embolization, and a genicular artery embolization. So the case mix there speaks for itself about our collaboration, what IR and vascular can do together. But right before I started my procedure, my other vascular surgery colleague popped his head in the door. He said, "Hey, is there anything I can do for you to get you out of here faster today?" And it's that sort of camaraderie. And who would have thought in a million years that vascular surgery and IR would have that level of respect and for each other and be able to really dominate when we put our heads together and leave the egos at the door and the turf wars at the door. So that was a little anecdotal, personal story from just 5 minutes ago. But, you know, I think with the advent of back table podcasts, where we see a lot of endovascular specialists coming and bringing their 2 cents, that's the purpose of this talk, is modeling that, but having it be an open forum where a lot of our attendees here can chime in. You know, this is new for us as well. It's only 2 or 3 years in the making, and I'm sure there's other models across the country that are doing similar things we're doing, but we've learned a lot along the way. And I think because we're passionate in what we do, and we want endovascular, minimally invasive, image-guided procedures to dominate the healthcare market, it's really important that people out there learn from us, ask us questions, push us to do more, and to think outside the box. So this is your talk, not ours, and we're here to answer questions basically for everyone out there who's interested to how we practice and what we're doing for our patients. That's awesome, because Steve and I had the over and under whether you make it or not. Steve's going to get the $50. I owe him one. I'll send it in the mail to you. I'll let you gift. But anyway, we're going to start off a little bit, just kind of understand a little bit. I'm going to ask you both just some questions and get your perspective on a couple of things. But first of all, for both of you, I'm always intrigued what brings people into medicine, but more specifically, what you into the specialty you're in? You know, what made you decide to do vascular surgery? What was that drive that brought you to there?
You know, it all has to do with ultimately your mentors. And for me, I was very fortunate to have a number of mentors that were very strong in the surgical field from a very young age. You know, my dad was a dermatologist, so you would have thought, well, why don't you do dermatology? But that led to going to a high school for health professions that got me into the operating room very early. It was back in the day where you could actually scrub into a case. And so I was actually in Fondren wing of Methodist Hospital in Houston, Baylor College of Medicine, as a 16 or 17-year-old kid. In a heart surgery around those famous DeBakey team people. And so that was a big impression, but it basically led to, I think, an idea of trying to get that technical and artistic mode of thinking through medical problems, surgical problems, that when I was first introduced to interventional radiologic procedures, kind of took it to another level entirely. So you can do, you know, what we like to see in social media as a little bit of a tongue-in-cheek phrase of with or without a scalpel, and to be able to kind of do that and have a larger palette, so to speak, to kind of create things solution-wise is the the big prize, and that's why I love what I do.
And Neal, what about you? Does it kind of resonate with you? What kind of brought you into interventional radiology?
Well, honestly, I didn't know about IR as a medical student. Steve being interested in vascular surgery early on, he definitely knew angiography existed. As a medical student, you basically think angiography is basically coronary or maybe cerebral. And so in my rotations, once I kind of heard about it, I just peeked in on one or two cases. This is 12 months before med school ends, and you hadn't even heard about a specialty that can do so much. I was taken aback and spent a month at UCSF working with, Bob Curlin and Jean LaBerge and even Ernie Ring. And I just couldn't believe it that I went through all of medical school, barely even knowing that this existed. And from there, I just saw two things. I saw technology and I saw creativity. And whenever those two things are in the same room, really beautiful things can happen. And solutions are made, and usually they're more efficient. So, whether it's cost savings, lower, bigger safety profile, shorter length of stay, just overall, I would recommend any of the procedures I do for a family member. And that means that I really believe in them. So once I saw what they were doing out there, I was hooked. It's just, back then you had to do 4 years of diagnostic radiology residency before doing a fellowship. And I'm very happy that the ACGME has allowed IR to become its own training program, because it really does deserve more than that 1 year fellowship to fully encompass all the great things that are going on.
Absolutely. Excellent. So you guys, you're in practice together, and you kind of have a practice together with regard to having an OBL ASC practice and working in the hospital, because you both are also on active staff in the hospital. How do you make the determination on what cases you're going to be seeing and treating in the OBL/ASC setting versus what you would do as like an outpatient in the hospital? What is that delineation? How do you choose that and choose the patients for who would fit into that OBL ASC appropriately versus what you're going to do in the hospital?
Yeah, I mean, from a surgical standpoint, I can tell you that carotids and AAAs and basically any big aortic cases for the foreseeable future are going to be in the realm of the hospital. The thing that's probably changed the most in my practice is the access to the OBL or ASC for the peripheral vascular cases, the dialysis access cases, the venous work, not just ablation therapy, but also deep venous iliofemoral cases. That's created a whole host of efficiencies that make it almost unthinkable some days to even consider going back to the hospital to do those.
That's a great question. And for me, my determination is, where is the patient going to have the best outcome? And I have to be objective about that answer. And more times than not, as long as I have everything I need to do it, it's going to be at the OBL ASC. The reason why is a patient's experience goes beyond the procedure. It goes with their one-to-one nursing, a nurse who knows their case before they walk in the door for pre-op. That same nurse is receiving that patient in post-op and knows their entire recovery and is with them till the end. We just can't find that in any hospital that I know of. It just would be too pretty much expensive, and to have that one-on-one sort of care. Secondly, we're tighter with our regimen, so the wait times, there's no delays. We can adjust the schedule to our liking, and so the patient's going to have a better outcome overall, because we have a dedicated time slot for them, and you don't get bothered by anything or anyone else, and you're not limited on what you can or can't use. If I want a particular stent or coil or catheter, I just call somebody in the industry and they're there to support the case, or they have the equipment I need. A lot of people are going to quickly assume that, because it's an office setting, that we're going to cut costs, and that's not the case at all. We're using everything we use in the hospital. So as long as we have everything, I do it in my office. Otherwise, it goes to the hospital if they can't have it done there for whatever reason.
When you guys are looking at your case mix, what is your typical day like? I mean, and I say typical, in medicine, there is no typical, right? That's kind of one of those funny questions. But if you're looking at your normal case mix, what does that represent to you? What is it going to look like specifically? Because you have two different practices. You have vascular surgery working with interventional radiology in the same building, same practice. What does that case mix look like for you guys?
Well, typically speaking, we've tried to formulate something really based upon the amount of energy that you may have on any given day. And for me, the highest complexity cases that require thinking on your feet and, having audibles, if to use a sports metaphor, where there's not necessarily a set plan. Those are the critical limb-threatening ischemia cases that are multi-level, above and below knee, below ankle, multiple entry and exit points, and they become very complex. So we usually do, on average, about 3 to 4 of those a day, starting first thing in the morning. And after each one of those cases, as we're turning over a room, I'll actually bounce over into another bay and do, a perforator ablation or a saphenous vein ablation. And then I'll go back and do another lower extremity case of some kind and do, any number of things for that case, then bounce back and do another ablation case. So it's, lower extremity vein case, lower extremity vein case. So it gets to be very, very compacted. And just as in surgery, you want to have minimal wasted movement. I think in an ideal setting, like an OBL or an ASC, you want to have minimal wasted time and energy. So it boils down to, on average, about 3 to 4 lower extremity arterial cases, 3 to 4 venous ablation cases, and then about 2 deep venous cases, and then a miscellaneous case like a dialysis access fistulogram type thing. That's a typical day for us.
And yeah, I agree. The compactness of doing a fluoro case, which is going to be a more complex case, whether it's peripheral vascular disease or a venous case, and then in between when the room's slipping over to take care of, smaller venous ablations, is the way we kind of make most of our time. My days can be variable. Today I did a genicular artery embolization, 2-level kyphoplasty, and a testicular vein embolization for a varicocele, and then I did a vein in between somewhere there. So, other things that kind of are peppered throughout my days would be, filter retrievals. I do quite a bit of fistulograms. I trained at Rush in Chicago, and as many of you might know, that area, I mean, we don't have a shortage of dialysis patients and declots and things like that. And coming into this practice here in our area, there is a heavy dialysis population. And once I entered the endovascular fistula market and started doing that, these patients really do become your own, and you kind of, want to make sure they're up and running and the nephrologist is happy and they're happy. So I do quite a bit of fistulograms throughout the week, which I love it. I mean, some people don't like dialysis work. I think it's phenomenal because that's the patient's lifeline, right? And those patients have such high mortality rates, and they're just really depending on just a few people in the healthcare community to keep them alive. And so I'm always pretty passionate about dialysis care. And we've seen a huge decrease in declots. So sorry, Pete. I mean, the cleaner. Pretty much reserving that for a couple DVD cases here and there. But no, honestly, we can see the difference from 2 years ago to today when our practice came in, whether it be for limb salvage, amputation rates, failed dialysis access, how many people with tunnel catheters are walking around. We've changed the entire landscape of vascular care here, and it's pretty evident.
No, absolutely. I mean, that's what we want to see, right? The synergistic care being able to prevent a lot of these things that are going on before they get to be the problem. So, I mean, that's kudos for you guys for being able to make an impact in your area. One of the things that, and I'm just realizing we're using terminology like OBL and ASC, and some of the people that are watching this may not even know the difference. So really brief, in a nutshell, can you give us the difference between an OBL and an ASC and what you currently have as far as your synergistic partnership?
Yeah, so I think an office-based lab is an area in procedural medicine now that has evolved to be probably the simplest model in doing some type of intervention in a physician-owned office. It tends to be a little bit more free of the constraints of regulation, which can be a blessing and a curse. But oftentimes the sinking of cost into that particular facility is orders of magnitude less than a larger ambulatory surgery center, or ASC. We've referred to those interchangeably during our discussion, but they're not quite equal. An office-based lab for what I do tends to be a little bit more favorable for a vascular surgeon that's doing peripheral interventions and whatnot. Whereas an ambulatory surgery center has other benefits where you can actually probably do more in certain respects. Without trying to oversimplify it, it's largely separated by the amount of regulation and the amount of capital investment that's required, where in an ambulatory surgery center, it could be, upwards of, multiple millions of dollars, whereas an office-based lab, sometimes all you really need is some radiation protection and image intensifier and staff, which is no small feat, but it's definitely not as expensive as an ambulatory surgery center.
And I think for any of the trainees or any younger physicians out there who are listening, the fact that we have to know about these things coming out of training is, I mean, it's a testament to what's going on in healthcare right now. So, understanding CPT codes and the way they reimburse under one compared to the other, and how that landscape is dynamic. I mean, every year they're shifting these costs, and all we want to do is be doctors, right? We just want to do our procedures, help the patient, and make a living off of this. But it's really, really important to keep your antenna up on what is going on with the reimbursement patterns, with the lobbyists, what they're doing with CMS, and kind of the rules they're making. Because if we don't band together and have a voice, at least, we're going to be taken for a ride. And I think that we're doing a pretty good job of stopping that. But many of you who are in IR are aware of the reimbursement cuts that are kind of evident going into 2022. Some of which we're trying our best to ease them from doing. But it's just important, because what Steve does, what I do, what many of you listening do, is we're so super specialized, and our craft is really unrecognized, I think, on the mainstream, because it's not a very advertisable thing. We're doing our best with social media. You're trying to show uterine fibroid embolization and prostate embolization and limb salvage, but these are very difficult things to kind of so-called advertise directly to the patient and to the community. So it's an uphill battle for sure, but the ASC OBL, what it does allow us to do is to have some control. And I think that's the most important thing, is that when physicians are in control of what's going on, the outcomes are usually better, at least in my experience.
So that kind of brings me, kind of following up with that question, and now obviously you guys are much more involved with the business end of the practice than you were, say, theoretically being employed either by a hospital or, a mega group or something. You guys actually own an entity where you're in charge of the business day to day, from the operations to the employees to the flow. Everything kind of falls in your purview of control. What are the advantages? I mean, how do you feel about it as business owners, as physicians that are also executives that are kind of providing this provision of care in this entity? What are the advantages of it, would you say, having that type of partnership in business? And what are kind of the disadvantages of being, for lack of better terminology, business owners and actually running the show from soup to nuts, so to speak, when your patients come through the door?
I think the biggest advantage is, as Neal alluded to, is control. We're able to control the level of quality and focus and attention to detail that's required to maintain a center of excellence model. In our particular facility, I mean, I've been blessed to work in some of the best institutions in the country. And I would put the level of work that we do in this lab, I would go toe to toe with them, simply because we've gathered the exceptional team members that are required. So the advantage of having an OBL or ASC is that we're not running an emergency room, and we're not doing things in the middle of the night. So the staff that we're able to call in have specific hours. And as you know, we live in an era of soul crushing burnout with COVID, and then having to come in, and for a lot of these folks doing STEMI calls and whatever, they're living in an exhausted environment. Whereas here, that we're going to come in, we're going to do world-class level work, and when we're done, which is typically at about 5 p.m., we're done. They get to go home with their families. To me, that's the biggest bonus of this structure, is that we're supremely efficient, but we get to have a happy team that isn't constantly, suffering from the threat of a potential emergency coming through the room or something. I think that's probably one of the most underappreciated values of having a facility like this.
And I basically just echo what Steve said. He said it perfectly. And when you talk about disadvantages, they are truly minimal. I mean, there's going to be maintenance of staff and supplies and equipment, billing, coding, scheduling, some of it we do in-house, but there's a multitude of outsourcing to consultants and companies who are experts at this stuff. But we really, assigning a dedicated person for X, Y, and Z, you have complete control of making sure X, Y, and Z turn out okay. And sometimes when it doesn't work out, there's the hiring, firing, there's the HR kind of component to it, but it's always done, with a smile, meaning, if you have to switch things around, it's for a good reason. It's for the betterment of the patients and for the whole organization. The other thing is I can count on one hand out of over 1,000 cases there of when I didn't have something I needed during a case. And really, it was only in the beginning. And what I realized is, hey, let's just keep one of those on hand, whether it's a certain catheter. I do keep a cleaner. It's not something that we're not doing declots in the OBL because that's just not where you do them. Someone with a really high potassium who's not feeling well, you're not going to be putting them in a case that could take over an hour in an outpatient setting. You're going to want them at the hospital. But I do keep one because you never know when you're going to need it. And so it's just, again, there's very, very few disadvantages to working in that setting.
Awesome. I got some questions that are in our question box. I think we're going to open them up and kind of address some of them while we're going, if you guys don't mind. The first question is, how do you partner with local hospitals, and do they behave differently with your case schedule there or treat you as competition? That was when I was actually joking around, because Steve and I were talking about that before we launched the webinar on what that reception is and how that works. I always call that's the bomb question I'm dropping on everybody. So how does that work for you guys? And just kind of share your thoughts on that.
Honestly, I think it's going to vary on, there's going to be a very regional answer to this. I was working in Albuquerque, New Mexico, prior to working here in South Dakota, where in that region, putting up a site like this would be met with, I think, vehement response, where you would get shut out of certain health plans, and they would try to steer patients away from you. And there may also be an attempt at trying to give you suboptimal times and access to their operating rooms. And so it can almost feel nefarious in some regions. And so I would say, if you're thinking about doing this, certainly do your homework on the quality of that interaction, because I think it makes a huge difference. I think the reason it works in this particular region is because it's a very underserved area. We still bring a tremendous volume of cases to the hospital, and we elevate the quality of care to those hospitals. And I don't think the hospitals are hurting as much as they may claim to the opposite of that. But again, to kind of finalize that thought, it depends. I wouldn't give you a simple answer. It's not a simplistic thought about this. This is very complicated and potentially hazardous if you go in this blind and not seeing a potential fall. New Mexico, to go back to that example, is littered with ambulatory surgery centers that are empty, that closed, that went bankrupt because of that.
Yeah, I mean, this is again, like Steve said, it's very regional, and in our area, you know, we have kind of a desert of lack of specialists at times, and you know, the ones that have maybe come through in the past haven't really provided the service that is up to par that we're providing. So it was kind of very fortunate that as an interventional radiologist, you know, many IRs out there know that that is usually tied up with the diagnostic contract and there's exclusivity. Well, that just wasn't the case at the main hospital in town here. So they understand they're getting, you know, university level world-class care. We're doing Y90, you know, there are trauma centers, so we provide that service. You know, we're doing, you know, vertebroplasty, kyphoplasty, spine jack. We're doing every high-end IR procedure inpatient for them. And I think, you know, the way it works is that they understand that I also have an OBL that I work at. So it's been great because I'm able to provide a service. I do have a mid-level. I think mid-levels in interventional radiology provide a wonderful service, whether it's doing consults, progress notes, thoras, paras, fluorexes, tunnel catheters, anything that doesn't need sedation. A mid-level can take care of that. And so that allows me to be, you know, to practice build or to be at the OBL or be in clinic and see more patients for follow-ups and do the clinical thing the way it should be. So I just happen to be fortunate and in a position where the hospital needs me basically more than I need them. But I think it's, you know, my duty to provide this community with that level of IR in the hospital as well. We'll be lucky to be having a second IR join us in the new year. So definitely we'll be able to kind of spread ourselves a little thinner. But like Steve said, it's a very sticky situation depending on where you go. There's a lot of old school exclusive contracts in place that make it hard for IRs to kind of do something like we're doing out here. So do your research for sure.
So are there competitive clinics nearby and do you collaborate? If not, how do you specialize to focus on different procedures like geniculate artery embolization to maximize your ASC? I guess that's an interesting one, you know, in the landscape you're in. How do you build that practice and kind of take some traditional procedures and turn them into these percutaneous procedures, maybe offering an alternative, you know, treatment and do it in a way that's kind of synergistic and not kind of competitive to people trying to, you know, feel like you're trying to impose in on their business? How does that work for you guys?
Well, I'll take this one first, Steve. You know, being here, I was able to introduce a lot of these procedures that they hadn't seen before. So we'll start off with oncology. Collaboration was as simple as going to tumor board. It was as simple as when I get a biopsy, you know, a consult for a biopsy, it was doing a consult note and calling the oncologist and saying, hey, you know, instead of doing six rounds of radiation, you know, radiation therapy for this, why don't we just do a thermal ablation of that T1A lesion? It was just that feedback. They had never heard that before. You know, they didn't have, and that goes for every specialty. So for GI, you know, they order a paracentesis and you're calling back and telling them what the MELD score was and recommending, you know, that they may need a TIPS or benefit from something like that. So once they kind of know that, you know, you talk the talk and walk the walk, it kind of just starts to, if you build it, they will come sort of sentiment. As far as competitive clinics, I mean, we do have people who so-called dabblers, whether it's cardiology dabbling in PVD, whether it's ortho or neurosurgery dabbling in kyphoplasty or vertebral augmentation. Pain specialist is another one. And I think just in our area, again, we're lucky enough that there's more than enough to go around. But at the end of the day, when the dust settles, there's only a few people standing who are standout at what they do, and the results speak for themselves. You know, we've relied very heavily on primary care and hospitalist services to refer to us, and just after a few months, they kind of see the difference of, you know, that true, you know, true world-class care and what they were getting before. How do you focus on different procedures like GA? Well, GAE is pretty new, you know, and we're just getting our feet wet with that. We're waiting for some official FDA approval, some more studies, some more robust studies. And it's really right now, orthopedics calls me. They said, hey, we have hemarthrosis, recurrent. We're tapping this guy. He had a knee replacement 6 months ago. Can you take care of it? And they really like the results. And we've had a couple non-surgical candidates for knee replacements who have osteoarthritis pretty bad. And we've seen some pretty good clinical results anecdotally from that. So again, I think that the collaboration is going to be, for me, showing up to tumor boards and you know, keeping in touch with our referring physicians, whether by phone or by clinic notes. That's the collaboration there, and not going rogue. You know, I've heard a story about, you know, an IR doing a biopsy and then decided to ablate it without talking to the oncologist. I mean, that's completely not the way to practice in any of medicine. As a specialist, you know, I know that we have special skills and we want to be autonomous and make decisions, but there are other doctors who are referring to you saying, hey, I need you to help me, not just take my patient, do whatever you want with them. So communication is key. If you're not calling your referring physicians on a regular basis to discuss what your plans are, you're going to be in for a rude awakening when you do something that they don't think is right. That's it in a nutshell, I think.
Yeah, I would just add in terms of limb preservation, which is probably the engine for my practice. It's imperative to remember that is absolutely a team approach. You've got plastic surgeons, you've got wound specialists, physical therapists, and you know, endocrinology, even, you know, your emergency room physicians, you know, orthopedics, general surgery. So it's not just a one person show. And as Neal said, I mean, it's extremely important to have a very high level of communication. And so each one of our physicians in this group has a physician extender or a PA or nurse practitioner that can help be the air traffic control for the service, as we just saw a moment ago, where Neal was in there doing a 2-level kypho, and his PA was kind of running interference and kind of working in the background, making sure that things were getting texted or HIPAA compliant, you know, messaged in some way to kind of communicate that the work was done on, you know, individual XYZ. I think that's extremely important, and, you know, probably what sets you apart from other competitors or other facilities that may pop up in a larger market. It's always going to be a differential of, you know, the affability, availability, and ability, to use an old adage. So, you know, as long as you can, you know, stay very in tune with your referring network and have them actually be a part of the care of that patient, I think you're gonna see who's gonna, you know, rise to the top. I think clinical research is also extremely important, and in engaging in a clinical research program, you have access to the latest techniques and technologies. We happen to be, you know, among the first to have the skill set to do deep venous arterialization, which is a very hot topic in limb salvage now, and was, you know, previously unheard of in this area of the country. You know, so bringing innovation, I think, is also a huge part of setting yourself apart from the other, you know, little pop-up stands that claim to be limb salvage centers.
And that's, you know, kind of playing off of that. One of the questions that's being asked, which is really specifically germane to you, Steve, because you do a heavy amount of limb salvage and PAD work, is do you think the proposed reimbursement changes are bringing about an end of OBLs and more cases will move to the ASCs? And I think because of mainly addressing the atherectomy change that's been proposed. What's your thoughts on that? How do you think that's going to affect your practice as well as other practices? Will that business shift over either back to the ASC or to the hospital, or what's your thoughts?
Mm-hmm. I think that I tend to agree that there is going to be a shift in the next several years towards the ambulatory surgery center. It has more to do with politics than safety or quality, because that's never been shown. So I think if you were going to get in the game now, I would seriously consider, you know, possibly looking at doing an ASC instead of an OBL. if you're still a holdout and doing primarily an OBL, hopefully you've already kind of looked around at your facility and see what it would take to possibly, expand yourself into that transition, which is no small task. I mean, I had mentioned earlier that it's in the millions of dollars, so you may have to partner up with other organizations and get some capital investment to make that happen. But if I was going to look in my crystal ball and say, where are we going to be within 5 years from now, I would say that more of it is going to be going to the ASC. I would sadly disagree with anyone that would claim that this is all going back to the hospital. That's never going to happen again. I think we've proven it beyond a shadow of a doubt that it's cheaper for the payers to do it in the ASC and OBL space. It's better for the patients to do it in the OBL and ASC.
So one of the things specifically, we talked about social media, and I think that's really big. We see that a lot in vascular surgery and IR, using Twitter to be able to leverage. What do you see as far as patients? How do you use Facebook, Instagram to connect with patients? Do you use social media for that? Do you use it for, as an outreach? What's your thoughts on that?
Well, I'll take this one. About when I finished fellowship in 2015, people started creating medically related social media accounts. At first, it was more of physicians talking to other physicians about topics or showing a cool case or maybe commenting on a new study. And I think some of that was positive, and then there was a lot of negative that came with it. And as I transitioned out here, when I moved from Chicago to Sioux City, I started to become hyper-focused on building my practice. And I realized that I wasn't getting value out of social media personally as a physician. And so pretty much stopped. And then, on the flip side, needing it for practice promotion and branding and for direct-to-patient marketing, it is something that I think everyone needs to look at and have be a part of their practice if you're running your own practice or business. So we definitely team up with digital marketing agencies, and you can get as much into this as you want. I mean, you can have it be a full-time gig, but obviously physicians are limited by our schedules. So it's really important to team up with people who know what they're doing, and have really, really good goals, and understanding what those goals are, whether it be, search engine optimization or click funnels that allow a potential patient to see something. Oh, hey, I have fibroids. I'm going to click here. And then all of a sudden they're at our website, or they're going to be calling our office by a phone number. So, I think it's very, very important. And I think it's pertinent to success in the long run, because again, referring physicians are only going to be one piece of this. The other piece of it is going against, at least for IR, is giving patients another option other than surgery. And I think for CLI, and more what Steve's doing on a daily basis, saving limbs, I mean, a lot of patients are just told they're going to get their leg chopped off, right? So the whole movement of, as kind of, funny it is, haha, hashtag stop the chop. I mean, that's great. I'm glad that's out there. I mean, patients need to be able to find Steve, and it's not always easy. So teaming up with digital marketing agencies, or having someone in-house who's a dedicated digital expert, I think is really, really important for anyone who's thinking about doing one of these.
Yeah, I would just add about social media. I've really gone back and forth with how I look at Twitter, for instance. Twitter can be a very confusing space. I tend to kind of have fun with it rather than take it too terribly seriously. There's a lot of personalities on Twitter. I consider Twitter more of a place for a casual discussion among colleagues and friends, rather than directing it at any particular patient. I rarely, if ever, post cases of my own patients on social media. I just have a personal, not a problem, but I just kind of shy away from that, because, that doesn't necessarily I don't necessarily think it's a bad thing. I think we just need to be very respectful with that. If it's something that truly is going to make a change in someone else's life by showing a revolutionary technique or thought, then I may chime in on something. But it's rare for me to kind of show like the actual angiogram and step by step. And there's a lot of folks that do it, and more power to you. I just I kind of got a little bit burnt out on some of that, because it seemed like it was just more of a, let me just show you how I flip my stick in the air type of a showy thing. And it just seemed a little bit, it wasn't tastefully done. And it's rare for me to see that. But when it's executed properly, I think it can be very valuable. The most valuable use of social media, as Neal alluded to, is the storytelling ability of being able to say this patient had a wound and was told they were going to lose their leg, and then went through an innovative procedure that ended up, saving this person's limb and ultimately their life, knowing the huge mortality rate of an amputation. That to me is a big difference from showing off a technique, and actually, maybe giving a little light bulb moment to a patient's family member, saying, oh, well, there's something that can be done, and let's seek help. I think that's a very valuable thing for social media to accomplish, if that's done.
Excellent. One of the things we talked about really is that synergistic practice, where you guys have the ability to work together and do things together for the benefit of the patient. I know that Dr. Khurana actually has a presentation of a couple of cases, kind of a quick case rundown of some of the cases that you guys have done synergistically, where synergistic care kind of made sense. So Neal, are you able to launch them from your computer, or do you need me to launch them and you just tell me next slide? It's up to you.
I should be able to launch them from here.
I'm going to stop sharing, and I'll open up the share to you so that you can share if you need to.
Okay. Okay, so I just put together some cases that, let me see, make sure I can do this PowerPoint.
Yeah, the little screen share button, the little green one. If you click on that, that should allow you to select your screen.
Yeah, it's just having me give permission here. We're on Ring Central. Is that what we're using?
Yes, sir.
Okay, 1 second. Okay, that should do it. Let's see here.
The difficulties in live real-time electronics.
Yeah, so let's see. I gave permission for my screen sharing, but I'll try it one more time. If it doesn't let me do it, then you may have to do it for me.
Not a problem. I can do that, and you can just tell me next slide, and I'll be more.
Yep. Okay. Why don't we try that out?
Sounds good. Let me pop that up real quick. There we go. Can you guys see that okay?
Yeah.
Slideshow. Let me do,
yeah. You want to go to slide 1?
absolutely.
That picture is a spoiler alert. So basically, this is a case, is a female with trauma, relatively younger. I was covering right when I moved here. I was covering for vascular. At this point, it was just me and Chad Lorich, who's my vascular surgeon partner, and she had a knife, going straight into her medial thigh, and they put a tourniquet up, and she helicoptered in. We're in a rural area, and 2 hours later she arrived with no pulse. Foot looked pretty bad, and they took the tourniquet down, and they had some bleeding. They put it right back up. We took her to angio, and this is what our first angiogram looked like. If you want to go next there. So traumatic occlusive dissection, and it was easy to cross, but as soon as I puffed, it's basically just a cast of thrombus from her distal ossifade / pop down into her, what looks like her AT, our PT and perineal as well. Next slide, please. So basically they took off the tourniquet, and this is what we're seeing right here. So she was hemodynamically stable, and I think this brings up a lot of discussion, and someone who has the training that Steve has would probably say, okay, just go to the OR and do a bypass, and go ahead and do Fogarty, all those tibials out. She's young, and I totally agree with that. And at the moment, just we didn't have the coverage available, and that's why it's so important to team up with. I think IR and vascular, have a huge future together if everyone just checks their egos at the door and get rid of the turf wars. And, we're able to spread ourselves a lot thinner and help more people if we stop being like, oh, we do endo in this hospital, so IR can't do it, or vice versa. But if we all are doing it together, then we can kind of split up the work with what's appropriate and hopefully do better for the patients. In this case, I put a covered stent, and then I vacuumed out everything with aspiration thrombectomy. Next slide. And she, had a lot of spasm down below. Next slide. That's just showing everything looking okay. And that's what we pulled out. We pulled out basically a cast of her pop and her trifurcation. It was pretty cool to see that come out. And you go next slide just to show the final angiogram. So again, the perineal was the basic runoff to the foot, with the AT and PT being pretty spasmed. But she showed up in clinic, and unfortunately for her, she was a very heavy smoker at her age, and which is another huge problem out here. And we did end up just doing her as an outpatient elective bypass, which my partner did, and she's doing absolutely great. But that was a cool case. I think, again, people can have their opinion on what should have been done at that moment. And, they have to understand that, we're in a locale where, things aren't always available all the time. We definitely changed that. This was almost 3 years ago now. We definitely changed the dynamic out here by having, full vascular service 24/7 for vascular surgery, which wasn't available here 3 years ago. So that's first case. Next case. These will go by a lot quicker. That was the longest one. This is a gentleman who had a AAA repaired outside hospital. That's another thing we see out here, is we see a lot of AAAs that aren't followed. They're done by who knows who, or who knows by who knows. Just 4 or 5 years ago, there was a smattering of different vascular surgeons coming in and out of town here. So we're left with a lot of poor follow-up. And this patient was just sent to me. I think their cardiologist noticed that the saccular component of their aneurysm sac was kind of getting bigger, and I ordered a CTA, and we saw a little leak there right adjacent to the IMA, which is pointed out in red. You can go to the next slide. And basically, this is something I love doing. I love going radial. And I know, there's a lot of people out there who love radial, and there's a lot of people who aren't experienced into it. But I mean, once you start doing it and get over the fear, radial is a great way for a lot of cases. And in this case, it was perfect. There's an arc of Rheolon connecting right up to the IMA. Next slide. We were able to get a microcatheter up into the sac, and you can see that in that video right there. The outflow was actually the IMA, and there's maybe a little lumbar that's an inflow. I can't really tell, but we just coiled that off and preserved the IMA outflow, and it was great. So that next slide, the follow-up basically showed, you go to the next slide there. The sac is kind of getting smaller, and there's no leak anymore. So kind of a cool case. Now, it would have been cooler if that was one of my partner's leaks and I fixed it, but
Sure, it would have been.
it was just some random person, who knows. Next case. This is a great case. So trauma, we're level 2 trauma out here. People get helicoptered in, and in this case, the 16-year-old about 2 hours away, hour and a half away, went off his ATV and looked pretty bad, but his parents didn't want to call an ambulance. They thought that would take too long. Little did they know, we probably would have sent a chopper to go get him and get him there a lot faster. But he showed up with a hemoglobin of 4 with a grade 5 spleen and left renal injury. Next slide. Trauma surgeon said, why don't you just stabilize him by doing a splenic embolization? So we did a MVP9Q here. We preserved, the vessels we needed to. So that was a picture perfect landing of a splenic artery embolization, and still have that dorsal pancreatic and pancreatic magna still there. So we know his spleen will probably still survive this at the end of the day. Next slide. And then, it had been about 2.5 hours plus for that kidney. And I was able to get across where the artery was pretty much torn and drop a stent there. But that picture you see is the aortogram, I'm sorry, the angiogram. And after that, there was no venous phase. So that kidney was pretty much toast by the time we got to it, but it was kind of just great to go ahead and at least be able to do it. And he did fine. He was discharged, never went under the knife. 72 hours later, I mean, young kids like that are really, they bounce back pretty quickly. And he kept a lot of his spleen. I got the CT in 6 months, and he still has quite a bit of his spleen left. His left kidney is completely shrunken down now. So next case. And this is a case, again, we have someone who did an aorta bifem, wasn't followed up. I don't know who did this, but some people were joking around that this was Gumby legs. The pant legs of the graft looked a little too long, and they kind of had, got sucked up and folded. And basically, he dehisced the top part of his graft, and he had an aorta enteric fistula. Lucky for the guy, he presented with hemoptysis and hematochezia, but it just magically stopped as soon as he hit the IR and he hit the ER, and he was normal. And we got the CT, and I was like, oh my gosh. So I was able to put a cuff up top. You can go to the next slide and just kind of seal that off. And then my partner, vascular surgeon partner, saw him the next day. We had him on antibiotics. And eventually, once he was on antibiotics long enough, took him for surgical revision of that and explanted everything else. And the guy's doing great. So, this is another point, is any IRs out there who are doing aortic work, you got to have a vascular surgeon around. I mean, you can't be messing around with this stuff without somebody who can do a cut down. If you end up with an iliac on a stick, you don't have a vascular surgeon to back you up there, you're not going to be doing AAAs for very long. So yeah, those are my cases. Very lucky to be out here to have Steve backing me up whenever I run into trouble.
Excellent. In the end, you guys kind of have shown that synergy and care, and it's an interesting world we're in. There's so much in changing with regards to techniques and the way that these procedures are being done. There's so much room for synergistic care, and instead of being competitive and trying to compete, and there's the realization that there's plenty of business for everybody. I think that everybody can come together and work, and not only work for themselves, but work to optimize that patient care and provide better patient care together. So I want to thank you both for participating tonight. Dr. Khurana, Dr. Henao, it's been fantastic. I appreciate having you both on here. Once again, everyone, thank you so much. This is the conclude our ACES virtual event for this evening. I wish everyone a very happy and healthy holiday, and looking forward to seeing everyone again in 2022. So thank you so much, everybody. Appreciate it.
Thanks, everyone.
Thank you.
Thank you, guys. Have a good night.
Thank you.